I would like to warmly welcome Tatiana Dierwechter, Nicole Corbin, and Jessie Eagan from Oregon Health Authority, and they are going to talk to us today about youth SUD and policy in Oregon. Welcome.
All right. Well, I'm Tatiana Dierwechter, and I'm the Alcohol and Other Drug Prevention Manager at the Oregon Health Authority. And my colleagues that you'll be hearing from after me, the three of us work together across what we call the enterprise, which is just a fancy bureaucratic name for the complex Oregon Health Authority system that we live in, work in, try to navigate, and then more importantly, try to navigate for our partners in partnership with community. And so today we are going to do our best to give you a policy snapshot of work that has happened recently and then previewing some opportunities ahead in the SUD youth policy space. And to help us get started on that, is this the magic wand right here that makes the buttons go? Okay, let's see if it works. All right, so there we are. And so I'm going to start with some level setting. There's many different ways we talk about the SUD continuum of care for youth and families. And there's no one right or wrong way to talk about and tell that story. We come from many different disciplines. We're trained in different ways. We work with different kinds of partners. And so this is just one way that we try to tell the story about the work that happens in substance use. And working with families, children, and in the case of public health, actually all of us with community. We'll be talking about some of the examples of both programs and policies that happen in that acute response. That's the top of the triangle, or the pyramid. Those are those life-saving, we talked about it this morning, right, with your first presenter, access to naloxone, and how do we get resources in the moment to people who literally can save their lives. As we move down the triangle, education, recovery supports, right? So even once people access treatment, we know that ongoing support and lifting up the hard work of that person, the individual, and oftentimes their families, those kind of supports need to be in place long-term. Screening and treating, thinking about how do we get folks to the services they need in all kinds of settings. And again, your first presenter, what a great job she did talking about the importance of thinking about SUD as a chronic condition, treating it just like we would any other health event in a person's life. And then for my part of our conversation today, I work here kind of at the bottom, more of the bottom of the pyramid. And so this whole body of work that you see on this side, they're just some examples of tools in what we call our primary prevention toolbox. To do things that change the context, that make it easier for people to be healthier. Sometimes you hear about root cause prevention, upstream prevention. It's really what are the programs and policies that we can put in place that prevent substance use from ever happening in the first place, or some of the related harms that go with that. Just a few examples already. You've talked about some of them already this morning. A lot of primary prevention work happens in schools, which is, of course, really important in terms of health education and curricula, supporting our educators to have the resources they need to work with children and families. Bullying and anti-violence prevention programs, both in schools and neighborhoods. Lots of focus on parent and family education. And then Wes, he hinted at this a little bit this morning too, the importance of youth engagement, youth leadership development, civic engagement of youth and their families. And then moving into what we call these bigger P kind of policy tools in our toolbox, coalition building, right? Anything that brings partners together to work on a complex problem together has a lot of evidence showing the effectiveness over time. Limiting advertising, age restrictions. The Indoor Clean Air Act in Oregon, right, is an example of a big P policy. And then I'll give you some more examples of some recent big P policies that we're really excited about, and the data's starting to come in, and we're seeing some of the impact around our new tobacco retail licensing and the raising the price of tobacco in Oregon, which just happened again about a year and a half ago. I also want to just point out, again, a couple folks have already done such a beautiful job of giving examples around social determinants of health. You know, these big levers around racism and trauma and toxic stress and poverty, you know, we don't think of these other tools over here as substance use primary prevention. But again, I just want to encourage you to think about your role around advocating, educating, being at the table, showing up to talk to your legislature, engaging your CCO to be like when you're working around universal home visiting, early childhood education, right? Making sure your families have access to SNAP and WIC programming, housing, home ownership, transportation as a major barrier, right? These are all, think of them as primary prevention of substance misuse or substance use. I am so excited to see what's going to be happening with paid family leave Oregon. We're so early, right? I'm sure that there are people from all over the country coming to evaluate what the impact of that policy is going to be on our state. And basically, anything that reduces family stress is going to increase well-being for the children and families you're seeing. So think of yourself as change agents in this other bucket of policy work, because it's so critical to our collective efforts. Here are just a few examples of some of the recent policy, Big P policy, and again, Wes touched on a few of these this morning. Our tobacco tax, you may have voted for it. I hope you did. Thank you if you did. This increase of cigarettes and other tobacco products went up again a couple years ago. I'm going to show you a slide next that shows the immediate impact of that. That raised a significant amount of revenue, most of it going into the Oregon Health Plan, but some of it also coming back to prevention. And so for the first time, in addition to funding all of our counties to conduct tobacco prevention work, we have now 94 new culturally and linguistically specific CBOs who are also doing this work in the tobacco space. So again, early but excited to see what's happening with that. Tobacco retail licensing passed in 2021. Brand new program getting stood up. We have our first round of data that's come in from our youth adult inspectors. And last year we had 26% violation of tobacco retail outlets selling to youth and underage youth as they came into the stores to purchase tobacco. That's gone down a little bit now. This year it's down to about 21%, but still 1 in 5, right? Outlets are selling to youth in Oregon. Stronger behavioral health standards. Sounds like there's some great work happening to increase behavioral health access through our school-based health centers. Wes mentioned SB 238, which is the legislation that passed last year around creating some new curricula supplements in schools. We're working with ODE and the Alcohol Drug Policy Commission in that space right now. Our Student Health Service survey, which is one of our best ways that we get a temperature read of what's going on with youth in our state, has added a new substance use initiation question. And so that will be the first time using it next time around, so that will be helpful. And then I had mentioned the newborn home visiting. Gut punch this week, seeing that CDC data around what's happening with infant mortality and maternal mortality in our state, as well as nationally. This is not the whole answer, but Oregon is one of the few states in the country that will now have universal home visiting for every single newborn baby and their families in Oregon. We've had some pilot projects, right, for the next few years. This is now allowing us to go statewide. And so that's a big lift and a big success. You all as a CCO, again, are in perfect position, right? To if if you haven't worked with a home visitor through this initiative, we can help you get connected to your people, right? So every time that baby leaves a hospital with their family, they have an opportunity to get connected to a home visitor and primarily a public health nurse for that screening, that linkage, and into the access to the other services. And Nicole will talk a little bit about why that's so important in terms of Nurture Oregon. Won't go into big detail about this slide, but I talked about the power of Big P. This is something we like to celebrate. Sometimes policy, it feels kind of wonky, and it's hard to get our arms around it, and does it really make any difference? And here's an example. In Oregon, we're celebrating the 25th anniversary of our tobacco prevention and education program. You'll see that yellow line is the national average going back to 1993, and the blue line line is Oregon. And for the most part, we followed the national trends around reduction of tobacco use and cigarette consumption in particular. But you see there were a couple times that Oregon actually did better than the federal picture. In 1996, when we passed Measure 44, Oregonians did that. You'll see those numbers continue to go down. And then I mentioned ballot measure 108 in 2021. That blue line is our most recent data. Pricing, raising cigarette taxes is an effective strategy for reducing consumption. And that blue line you can see in the last 2 years, we've seen a significant decrease again already. So thank your local tobacco prevention policy coordinator, because if you didn't know, you actually have one. Every single county, thanks to this comprehensive program, we're one of the few states in the country that meets CDC's definition for a comprehensive tobacco program, has at least one, sometimes more, tobacco preventionist in your community. We also fund 8 regional health equity coalitions, and so those coalitions, we talked about another evidence-based strategy for mobilizing and resourcing good work in this space, and then I had mentioned our 94 new CBOs. We also have an alcohol and other drug prevention coordinator in every county. There were a couple here this morning who weren't able to stay, and then for the first time again are funding some new CBOs along with regional overdose prevention programs. Interestingly, our overdose teams, that's the least well-funded right now, even though right now we're in a crisis, of course, around fentanyl and polysubstance use overdoses. But they're there. They work regionally with their sister counties to stretch the resources. And so one of my messages to you is that this work of prevention is not something you have to do by yourself, that you have partners around you, and we can help you get connected to your local preventionists. And I think that's it. I'm going to hand this over.
Watch out for the light. Hello, everyone. I'm Nicole Corbin, and thanks for having me. Really glad to be here. I have to say, the last time I was at an event at the Melody Ballroom, it was what's called the Swashbucklers Ball, which is a pirate festival. And the view on substance use was very different than what we're talking about now. So we have the whole spectrum. Tatiana mentioned sort of big P policy, and so I want to talk a little bit about the big P policy around the treatment part of the spectrum, right? We talked about prevention, which we all know, especially working with youth, right? Anytime we can prevent the problem in the first place or prevent the problem becoming worse in the first place, we make so much of a difference downstream. And that doesn't always happen, right? We know that we have to have treatment, we have to have other resources. So I want to talk about the overall policy vision for Oregon, which is, right, the vision of the Oregon Health Authority is a healthy Oregon. And the substance use disorder team's vision, our role, is to develop, sustain, and oversee a quality system of care. And what that means is that we want people who are using drugs to have good health and have interventions that are going to help them, right? They're based in promising practices, they are culturally appropriate, they're centered in harm reduction, and they're trauma informed. That's what we are striving for. Oh dear, all right. Hey, okay. So our vision for the future, right? We are in a really promising and yet stressful place in the world of substance use disorder right now. Everyone knows that we have an overdose crisis, right? Everyone knows that we have seen the illicit drug supply in Oregon in just the past few years move to a point where more than 80% of the drug supply is fentanyl. So when you have someone who thinks that they went on TikTok to buy a Xanax, right, it's probably fentanyl. If they think they're using Molly, it's probably fentanyl. If they think they're using heroin, it's probably fentanyl. So we are in this place where we have this tremendous crisis, and that equals an opportunity, right? When people are willing to pay attention to substance use disorder, we have the eyes of the legislature, the eyes of the governor, and so we have an opportunity to make some investments and make some changes. So I want to agree with Tatiana that all of you should advocate wherever you can, right? Advocate to your legislators for investments in evidence-based practices, right? We know that treating behavioral health disorders and behavioral health needs has been underfunded for at least 30 years, and that child and family work is even more underfunded than adult work. So I put that out there because our vision of the future is that we want to increase access to treatment, right? We know that treatment works, right? Prevention works, treatment's effective, and people recover. But we don't have enough of that centerpiece. We don't have enough of any of the pieces, right? But we want to expand residential SUD programs, in particular, including parenting programs, right? Because if you've got someone who is struggling with a very serious case of the chronic relapsing disease of substance use disorder, and they need a residential level of treatment, it can be a tremendous barrier to them if they are a parent and they don't have somewhere for their kids to go, right? What a vicious choice to have to make, right? I can get treatment for my illness, but that means I'm a bad parent because I can't keep my kids, right? So we have a few programs in the state that are parenting programs where you can go for treatment and your children are able to be at the program in daycare and have some enriching activities there, and our goal is to expand those, right? We have just opened an additional recovery high school in Oregon, which is very exciting. That means we've got 2 now. Recovery high schools are real schools, right? They are accredited programs, they provide education, but they have a philosophy and a focus on helping kids who have experienced substance use disorder to stay in recovery. They have peers who have similar experiences. They work to fight the stigma so that people are not ashamed to be there. So reducing stigma actually, and rate increases, right? We've had a couple of rate increases to pay more for these services. We need to advocate for more for different specialty kinds of service, and that's part of our future planning. But reducing stigma is so important, right? Again, everyone here knows that especially parents who use, right, are subjected to a huge amount of stigma, and there's a lack of safety for them if they seek help because the risk of them losing access to their children is very, very real. There is a lot of bias and stigma about kids who use as well, right? That they're bad kids, they're a bad seed. And we culturally still, unfortunately, tend to believe that substance use disorder is a bad choice, right? Is a moral failing. We are all the inheritors of generations of a system that was created that was created with racist and biased underpinnings, that was created to make substance use disorder a criminal act instead of a health condition. And because of that, we are all still dealing with that stigma, and that is a huge barrier to getting people what they need. So that's, I have a lot of passion about that. We also want to improve data collection and analysis because that is where we get to focus our investments and focus our work in ways that we know are effective. Tatiana talked about pilot programs, so I want to talk a little bit about one of our pilot programs that is focused on families, right? And that is called Nurture Oregon, right? And I just talked about the fact that parents who use drugs are incredibly stigmatized. And pregnant women, pregnant people who just gave birth and use drugs are the most stigmatized, right? There are different places in the country where there are legal requirements that if a infant is born with evidence of drug exposure, that they're automatically taken away from the family. And again, we all know the traumatic impact that has on the parent, on the child, and it doesn't lead to good outcomes. So one of the programs that we are doing in pilots, we started in a few counties, in the legislature funded us for more, so this is something that we're hoping to continue to expand. But it's Nurture Oregon, right? And the role of this is to keep families healthy and unified by making sure that pregnant people who use drugs get all the same care that any other person who is pregnant or was giving birth gets, right? We want them to have access to obstetrics and to well child visits and to all the treatment that everybody needs that they often don't get because of that bias. Our core elements are that we want It includes clinicians who treat the individual before and after birth, right? That they have access to substance use disorder treatment, including access to medication. Again, I talked about how our illicit drug supply is virtually all fentanyl, and the most effective, the most evidence-based practice for treating opioid use disorder, fentanyl disorder, is medication, right? It's methadone, it's buprenorphine, it's Vivitrol. And again, there's still that bias that people who need those medications are sometimes denied them because they're seen as risky because they might use drugs, so we don't want to give them a medication to help them not use drugs. It's a very vicious cycle that our parents find themselves in. So Nurture Oregon makes sure they have access to medication if they want it. We have peers and community on the ground to engage families, right, so that their contact is not with perhaps protective services, right? Their contact is with someone who feels safe and who is welcoming. There's a case management team. We include trauma-informed care. We have facilitated support groups with Nurture Oregon participants so that, again, they can support one another. We offer services like doulas and housing support, home visiting nurses. We empower these parents, these mothers, these people who are giving birth to make their own plans of care. We don't dictate it to them. We have a transparent relationship with child welfare because, again, as we were sort of talking about consent earlier, right, we have to be truthful because there are legal obligations, there's mandatory reporters. So there is a relationship there, but that relationship doesn't have to mean that children are automatically removed, right? And having that truthful, transparent relationship goes a long way towards creating trust. So this is our information for October 2020 through May of this year. We had 277 participants. More than half of those folks were not stably housed, right? They were couch surfing or they were houseless, and there's a huge correlation between being houseless and polysubstance use, right? So most of these folks, more than half, were using multiple substances. A lot of them were using methamphetamine, which again, we hear from some of these folks that that's a safety issue, right? If I'm houseless, I need to stay awake so that I can protect my stuff or so that I'm not attacked. And again, we in Nurture Oregon approach without judgment, right? It's not, wow, are you a bad person for using meth? Haven't you seen Faces of Meth? Don't you know that's gonna hurt you or your baby? No, we understand. There's a reason for that. 41% used heroin. Again, I pitch that this is what the individuals think they were using. I would say they are also probably using fentanyl in thinking that they were using those. But of these 277 participants, 84% engaged in peer services. Right? That's amazing. That's fantastic. And 64% of them went ahead and accepted and engaged in substance use disorder treatment, which, again, that's fantastic. More than 70% of them got that prenatal care that we were talking about that's so important for having a healthy pregnancy, having a healthy baby. 81% of infants who were born to these individuals who were mostly homeless had at least one well child check, right? They got all those services that they need to help them have a stable start in life. And yeah, 85% engaged prenatally, and a good third engaged each trimester. So we're very proud of this. This is one of those examples of a pilot project that is keeping families intact and that is therefore helping to break the cycle of substance use disorder that leads to all of the challenges that we're dealing with today. And so this is the kind of pilot project that we hope to expand. And so I, again, make the pitch that when you are advocating, right, for when you're voting, when you're talking to your legislators, when you're advocating in communities, that we love to expand evidence-based practices and we really love to reduce stigma. And I give that as an example just because I am normally sort of the face of the adult substance use disorder world, and this is about, as my child and family colleagues always remind me, right, adults have children. Children have adults. And so we need to support them all. So I wanted to give that as an example of one of the programs that we're using. And then I want to give Jessie the opportunity to talk about more specific continuum issues for youth and families.
What are the two high schools?
One of them is Harmony and? We're in Riverside, yeah. Rivercrest, sorry.
MESD operates.
Yeah. Yeah, and there's more coming. Yeah, Harmony has been open since 2019? Yeah, a few years now, and it's showing great outcomes. Rivercrest just opened, so.
Thank you. All right, let's see how this goes. Hi, I'm Jessie Eagan. I was not at the Swashbucklers Ball, so I don't know that I've spent a ton of time in this room before, but there are quite a few friendly faces in here, and I'm very happy to be with you actually in 3D. I love this. I spend all day in virtual meetings, so this is lovely. Let's see if I just do that. Ah, lovely. Okay. So first I wanted to just talk a little bit about the youth and young adult continuum, kind of more broadly. To Nicole's point, we're talking about the substance disorder continuum, but within youth and young adult services, we actually have created this kind of new graphic looking at all of the different pieces of the system. And part of that really is because in our unit, we're trying very hard to destruct the wall between mental health services and substance use services. I truly don't believe that there is a huge gap there. I don't know that I've ever met any young person who was using substances who did not also have some sort of trauma history, mental health situation happening. They feel very, very intertwined. So we have built substance use disorder treatment into kind of the larger continuum. Most of you probably work somewhere within this continuum, but we really are trying to build out a full spectrum all the way from prevention, promotion, through community and home-based services, specialized services for young adults and for early childhood to give the full spectrum of the entire age range from 0 all the way through 25, and then also residential, which is often where people think of when they think treatment, they think residential. And so we're trying to kind of break that down a little bit and really make sure that people think about the entire spectrum. So if we go a level deeper, we get into all the different pieces of what sort of make up this continuum. On our website, which is actually one of the resources in our packet, so hopefully you'll have the link, there is actually another level as well where it goes into all of the different pieces of this. It gets very visually messy. None of you want that on a screen right now, but it does actually go in even deeper. And so I wanted to just call out that there's a couple of places where we are really looking at substance use services more specifically as part of this kind of larger continuum. So the residential programs do run through our unit, and we are working really closely with the adult system, with public health, to be part of that prevention kind of continuum as well. So just some data to go along with some of the data that Nicole had already discussed. If we look at specifically the information that we're seeing around Oregon's youth, there are national trends. So the national line is the orange line here. The blue line is Oregon. And what this is looking at percentage of youth with a documented substance use disorder. And in order to have a documented substance use disorder, they are in treatment. It means they have a diagnosis. And what you can see here is that the good news is that documented disorders are actually going down as a general trend. The bad news is that Oregon remains above the national average, and more recently we've actually had an uptick in diagnoses for youth with substance use disorders. Couple of reasons for that. I'll look at my notes here. The numbers actually are quite low, but obviously this is from 2016 to 2019. Our concern in using 2020 as an additional year is 2020 was a little off baseline for most of us. Things got real weird. Substance use disorder did actually go down. So that's actually a really good thing. What we found is that a lot of young people were at home with their families and had less access to using substances. And what we also know is there were a lot of other complications and mental health concerns that were coming out of being at home and during a pandemic and all of those things. So showing you 2016 to 2019 here. Our goal is then to actually get a couple years out post-pandemic so that we can sort of use 2020 as a little bit of a blip, but it's really hard to do this kind of longitudinal comparison with a pandemic in the middle of it. The other thing that I want to call out is that the numbers actually are much, much lower. So you see, like, what we're looking at is, 5.77, 4.08. That is percentage of youth of all youth in the entire population. It is a very, very small number. The other thing that I want to call out, just in this year, we talk about the crisis and fentanyl and all of those pieces. There have been 14 overdose deaths of young people younger than 18 in Oregon so far this year. Saying that out loud is really difficult because I think any death is a huge tragedy. And I also want to make sure that when we talk about the crisis and when we talk about kind of what's happening broadly, a lot of the real huge impact that we're seeing is on the adult side, and the numbers for folks who are dealing with these really significant disorders for young people are actually quite small. Again, that doesn't mean that we should ignore it. I just want to kind of put it in context. Yeah.
Thank you so much. I love a good graph. And I'm curious around like how we navigate looking at this, because like when we're talking about documented, they have to be in treatment, they have to get a diagnosis. And I'm like, okay, well, maybe we're better at getting people into the door. Maybe we're better at getting kids services or youth services. So like I'm thinking about other states that might not even consider diagnosing someone or getting them into treatment. So like, how do you navigate what to think about this? Like, should we be looking at this of like, oh man, we are like higher and that's a concern, or should we be looking at this as like we're higher and maybe that's a good thing? You know what I mean? I don't know.
Absolutely. Yeah. I mean, I don't think you're wrong. And I'm not going to say that we should look at it in any particular way. I think what I would do, and I'm going to channel my inner Wes because he was talking earlier about youth engagement. I think what we should do is ask young people what they think is happening. I do think that you're absolutely right, though. There's a possibility that seeing that number go up is actually not necessarily a bad thing. If there are youth that are needing treatment and not getting it, seeing that increase actually could be a good thing. It could mean that we're actually getting people into the treatment that they need, that we're breaking down some of that stigma so people are able to talk about it a little bit differently. They're able to come in and actually get the treatment that they are needing, that they're talking with their families and having those conversations. So just the fact that there's an increase doesn't necessarily mean that it's bad. And that's where I think youth engagement is really key. So, speaking of youth engagement, Nicole mentioned the student health survey, Tatiana, you mentioned it. This is data from the 2022 Student Health Survey, and what you can see is these are percentages on the side. We have the percentage of folks that drank alcohol in the last 30 days, that used marijuana in the last 30 days, that misused prescription meds in the last 30 days, and then used tobacco. The other one that we're including in there is gambling. It often gets ignored as part of sort of the continuum of like substance use, but there is a huge correlation between problem gambling, particularly in young people, and substance use. And problem gambling gets ignored by a lot of providers. We don't necessarily ask about it in our assessments, and we need to be kind of considering that as part of this spectrum because it is an addictive behavior and is really related. There's a couple of things about the student health survey. Not all schools participate currently. There are efforts to make sure that they do. A lot of the reasons that we see that not all schools do participate is because schools often have their own surveys that they are doing, and so they have extra questions. So it doesn't mean that they're not engaging in those kinds of questions with their student population, but it does mean that they're not using sort of the larger state one, so their data is not included in here. So we're working on kind of trying to get really consistent information so that we're getting it for the entire state. And the other piece that I wanted to pull out here is the connection between these behaviors that you're seeing, some of them as high as 20-25%, and suicidal ideation for young people. Because if they do have that stigma, if they do have an inability to talk with their families about it, if you are providing services to them and their families aren't aware that they're in services and struggling, that is another additional risk factor that we want to make sure that all of the folks working with these young people are considering as well. So this is where I've got many words to say. So youth and young adult services. For one thing, just even talking about young adults, our unit has really been doing a lot of work to sort of carve out a kind of a third age group of young adulthood. There are Medicaid efforts to make sure that those folks have additional services that are available to them, that we really are making sure that we're looking at what those unique needs are. Most of the information that we have sort of a kid system and an adult system, and that there's sort of an assumption that on your 18th birthday, there's this magic wand that happens, and you are miraculously turned into a fully functioning adult. And what we all know is that's clearly not true. And so looking at that 18 to 26-year-old range and thinking about what their unique needs are, they are adults, they do need to be considered differently, and putting them into a treatment program with a 60-year-old or a 50-year-old is probably inappropriate as well. And so really trying to carve that out. And all of our data, when we look in our unit, and the kids and families unit, we are looking at all of the information from young people and then all the way through that kind of age 25 up through the 26th birthday as kind of our youth continuum. So what we're doing in our unit is really looking at that full continuum: prevention, harm reduction, treatment, recovery, as kind of part of a fully functioning system for these young people. Looking at co-occurring disorders, I mentioned really breaking down those walls between mental health and substance use disorders, and really considering them as part of kind of a holistic model of treatment. Really trying to make sure that all of our programs have a family-centered approach. I think what we all know is that for the most part, trying to pull a young person out of their environment, treat them, and then put them back into an environment is just functionally not going to work. And so what we need to make sure that we're doing is always building in family supports, making sure that family are involved. Often we have young people who don't want their family involved, and so part of the treatment is to be able to talk through those things. What's getting in the way? How can we talk with your family in a way that's going to bring them into treatment and help them gain empathy for what you're doing, really work with the entire family system. You've probably heard a little bit about Measure 110. That is the measure that decriminalized substance use disorders, and in replacement, then the idea is to build in treatment so that people who are dealing with substance use concerns are not being sent to jail, they're being sent to treatment. There are services that are being built in, so we are working closely with the Measure 110 folks to make sure that there are youth peers, that there are youth services, including that young adult range, in the behavioral health resource networks that are being built across the state, and really making sure that youth services are kind of built into that whole process. We are building peer supports into all of the programs that we have, knowing how important peers are to youth and young adults, really making sure that there's someone who has lived experience, who can walk alongside, who can be part of those conversations with them. And CCBHCs, Certified Community Behavioral Health Care Clinics, I think if I've got the CCBHC acronym correctly, there are SUD services and mental health services that are happening in those environments. And what we're looking at the statewide level is the CCBHC program has been in place for multiple years at this point as a pilot. And the idea is to then make a decision of, are we expanding this across the state or not? And so there's conversations now of like, what are we going to do about that, and making sure that we're having those conversations around the services that are being provided, and what that will look like if we expand across the entire state. So that is many words. The key things that we try to make sure that we are always keeping in mind when we look at all services through the Child and Family Behavioral Health Unit at OHA is two things. One is all youth work is prevention work. Everything that we do with a youth or a young adult is prevention for the adult system. And the other is the piece that Nicole mentioned, which is families or adults who are in adult treatment programs often have children. And so making sure that we are linking that. Kids have adults, adults have kids. And so we really cannot kind of continue to have these systems function as if they're independent, because they don't. All right. A couple of highlights, wanted to call out, there's 2023 legislation. One of them is House Bill 2395. What it did was allow for the distribution of opioid antagonists and kits. Think Narcan. That's much more available now. So if you do not know how to access Narcan, you should have it available in your office, in your treatment environment, in your car, anywhere that you go. We want to make sure that everyone has access to Narcan because it is the primary way to save lives for fentanyl. House Bill 2767 is the bill that expanded the recovery high schools. It's what has allowed us to already add one additional recovery high school. What it does is build in funds over time. So by the end of this biennium, so within between now and the June of 2025, there will be a third school as well, and then 3 more, and then 3 more. So building in funding for the Oregon Department of Education, ODE, to actually expand that. And there's a community environment or a community group that is working to develop the plan for that and what that expansion looks like. So we'll be involved in that. There is House Bill 3610, which is the Task Force on Alcohol Pricing and Addiction Services. Again, looking at what does it look like when we look at pricing, how can we address substance use and ideally drive down substance use and substance use disorders by looking at the pricing. And then we already mentioned Senate Bill 238, which provides funding and a process to get some education into schools on the risks of substance abuse. More things that we have going on. There's a lot of workforce efforts. Hopefully this is a reminder, because some of these are a couple of years old at this point. But given Nicole's point around the complete underfunding of behavioral health for at least the last 30 years, there have been some investments into the workforce. So House Bill 2949 gave an $80 million on wage increases. So what we saw is that money went out directly to organizations, to counties, to community-based organizations, just to increase wages for staff. And then an additional $132 million was put out through workforce incentives from House Bill 4004. With an additional $3 million to raise residential rates and overall rate increases. So what we're looking at is trying to figure out all the different places, making sure that all the folks who are doing the work are making more money, that we are also really trying to increase recruitment, and then also retention, so that we can get folks into this field and keep folks in the field, because we know that when people need treatment, we need to make sure that they actually are getting that treatment that they need. And we have done a rate study trying to build in regular increases then into the process, so that when we go to the legislature, we can continue to ask for the true cost of treatment to really kind of build the workforce that of all of us that are doing this work. There's another piece around culturally and linguistically specific services. There are additional higher rates that are available specifically for folks that are doing culturally and linguistically specific care. And that can be a specific provider, or it can be an organization. There are higher rates that go out for those folks. And there is currently a new team that at OHA working on behavioral health workforce, and they are working on things like making sure that everyone has access to either free or affordable clinical supervision if you're working toward licensure, that there's an increase in loan repayment. They're looking at stipends for housing and for childcare, and then also really building in a pipeline so that young people are considering this field and coming into the field in higher numbers, particularly looking at culturally and linguistically specific providers if we can. So going into high schools, going into community colleges and saying, hey, have you considered working in the mental health or substance use fields? And we're really interested in having you come in, and we're gonna make it worth your while with all these other pieces. Breath. Okay. More. We're trying to bring in youth voice wherever we can. So we just had the first Youth and Young Adult Prevention and Recovery Symposium. It was held in Eugene. It was designed to be for the entire state. Over 200 people came. The very first time we had the Behavioral Health Director, Ebony Clark, present, as well as some legislators, really trying to bring in information about increases in peer work, in family work, bring in the voice of folks with lived experience, particularly young people with lived experience. So trying to really get all of those messages out in kind of a larger forum. There's also the Alcohol and Drug Policy Commission, ADPC. So they also have a summit and a workshop. They are developing a youth-specific group to really work directly with our team. And there's OHA Public Health Department Youth Advisory Committee that Wes mentioned earlier. So all of those places are ways that we're trying to really bring in youth voice so that we can be guided by what they need and what they're saying, and really ensure that we are meeting their needs, not just guessing, because nobody wants to know what a middle-class white lady thinks about what youth these days are doing. We want to directly hear from them. And we've got more funding coming. So within our unit, we actually just released a request for proposals. It has 5 different parts of it. It was ridiculously complex to write, but we couldn't decide what we wanted, so we wanted all the things. So we have built-in opportunities for expansion of school-based prevention. So school districts or folks working within schools can apply for funds to do that sort of prevention work that they're doing in schools. Additional peer supports, particularly peer supports for young people who are coming out of residential programs and need someone in their community who can help maintain their sobriety and really kind of help them come back into their community in a way that supports their sobriety, as opposed to just plopping them back in with all of their friends and where they kind of fall back into old habits. Additional supports for particularly residential providers to bring that family involvement and treatment in. So looking at evidence-based ways to bring in family involvement into substance use residential programs, looking at culturally specific substance use programs for youth, and then also looking specific at ways that we can get harm reduction services and education out to communities, particularly some of the more rural communities, but we're getting information out around some of the prevention work that is availability of Narcan, just general education about the system and how it works and how to make sure that we've got resources flowing. just in case you know anyone or are interested in applying for all of this, if any of that sounds interesting, it is up on Oregon Buys. And the way that we have set it up is that folks can apply for one of those areas, and that's fine, or they can apply for multiple, whichever is appropriate. So hoping to just get information out there. And that is all of my words, and I'm going to pass it back to Tatiana. We're trying to build in some time for some questions, but she's going to wrap us up.
Yes, and I'm just looking at the time, and so again, you can see, right, so much that we can share. Hopefully we're able to provide a little snapshot today of the investments that the Oregon Health Authority is making across prevention, harm reduction, treatment, and recovery for youth and families. These are just a few more examples. We've mentioned a few already. There's just an incredible time to be doing this work right now. One of the things that has shifted with the new governor is, as you may know, she has prioritized behavioral health as one of her top priorities for her administration. And I think it would be fair to say that we have felt that ripple almost immediately. There are conversations happening with policymakers, with commissions, with new legislative committees that we have never had, at least in the 5 years I've worked at OHA and probably longer. So there is interest out there for prevention in particular. I was just in Washington State last week at their statewide summit. It sounds like it's kind of a national conversation about going more upstream, working with youth, children, and families, recognizing the importance of these investments as part of long-term solutions. And so there's lots of ways to stay involved with us, and we hope that this will be a continuing conversation. Invite us back. Wherever your conversations are happening in your community and with your partners. And this is hard, deep work. And it's dark. And some days we're all collectively exhausted, right? But there's also a lot of opportunity right now. And, going back to that big pyramid, there's no one strategy that's going to move this needle. We need investments at every one of these layers, and we collectively have to be working together. These are seismic changes, seismic impacts on our children and our families, and it's not going to get any easier. So thank you for being part of the journey of doing this hard work, and happy, I think we have a few minutes if anyone wants to do any follow-up or any feedback you want to give us. We are the government, so we're here to hear the hard stuff too, about what's making your lives more difficult, about what OHA does or doesn't do. So we just welcome any feedback or follow-up. And I think is the contact info. Okay, great.
I have a question because what you said about the CCBHC SUD program piqued my interest. Was that a state-operated facility, or is that a contracted program? And can you talk a little bit about it, like what it's done? Or is that something like maybe I could follow up with you and find out about?
I was going to say, we are not the experts in that program, but we can get you there. My understanding is that there is new opportunities to update the standards for school-based health centers with a deeper focus on behavioral health. Correct me, CCBHCs. Mixing up my C's and my B's and my... I don't feel like I'm the right person to answer that question. Yeah, send it back over. Sorry, I thought you said schools.
Oh, yeah. School-based health centers are increasing their access and their standards for mental health supports as well. But CCBHCs, I believe there were 6 of them. There's a relatively small number across the state, and they were like LifeWorks Northwest was designated as one. Who else? And there were multiple around the state, and so they're very specific programs that had applied for that designation and have been doing the work since. But to Tatiana's point, we are not the experts, and so if you have more questions, I'm happy if you want to reach out to me, we can connect you.
Thank you.
Yeah.
This came up in a previous training about working with Oregon Youth Authority and their residential programs and making sure that they're able to take kids who are getting like medication-assisted treatment. Right now, like, that's not possible in most residential settings, and so just working to advocate for Oregon Youth Authority to change that.
We do not work for Oregon Youth Authority, but we work closely with them, and they do a lot of substance abuse treatment within their settings. The residential programs that we have through our unit that are for youth that are not adjudicated to OYA, they do allow for medication-assisted treatment within them, except for one. NARA does not currently allow for that in their program. But other than that, they will support medication-assisted treatment within their.
Who are those? Because I get pushback.
They are Madrona, Rimrock Trails, and Adapt. Okay. If you are having that issue, please reach out to me.
That's a piece of the stigma that I was talking about, right? There is still, even within our field, even within people who genuinely want to help kids, who have good hearts, there is still a subset of people who perhaps think, why would I want you to be on a drug to get off drugs? That doesn't make any sense. We know we actually have decades of evidence that says that having access to medications for opiate use disorder saves lives and helps people stay in recovery. And administrative rule and Oregon law both require that you cannot require someone to titrate off a medication in order to have access to their treatment. So I believe you when you say, yeah, they're doing it anyway. So when they're doing it anyway, when you have that problem, please do reach out to us, because we want to help educate and support and solve that problem.
Yes. Thank you. And I forwarded the slides to make sure, hopefully you all get these slides, because there are links in the resources, but all of our contact information is here as well.
Since we have a bunch of people in this room who have not had the experience that of what you're describing, of what maybe should be happening, what is the most helpful way for us to collectively perhaps maybe highlight this issue that I don't know anybody who has successfully gotten a young person into one of those programs on medication-supported recovery. Okay. But for the rest of us, who maybe are not having that experience, like, should we just all email all of you, like, where we're from and that we've
yes.
referred, that we've, like,
recently really,
talked to people and
absolutely.
had patients denied treatment?
Obviously, there's a challenge, right? Because if you have a specific individual that you want to help, then you want to share that individual's information, but you also don't want to share that individual's information because it's protected health information.
So it's more like, I have
But
recently.
yeah, please, it really helps us if we know specifically, like, what was the residential program you were trying to get into? What was the reason that they said this person could not be there? What CCO were they working with, right? Because our CCOs have some different prior authorizations and policies within them. And again, there's supposed to be no prior authorization required for medication for opiate use disorders. But again, when things are supposed to happen, that doesn't always mean they do happen. So yeah, please. I would say leave Tatiana out of this one. But if you want to email Jessie and I and let us know
Jessie
when these
Nicole,
situations happen.
okay.
Yeah, we want to help solve that problem.
And then since I work directly with the Multnomah County Youth Corrections System, would they also could I give them your information as the folks to contact, since they are also having difficulty with that? Okay, great, thank you.
And I would just say, again, from the policy perspective, the Alcohol Drug Policy Commission meets the second Monday of every month. There is open opportunities for anyone to come and share what they're experiencing and seeing on the ground. And it's an opportunity to also directly impact the strategic work that the Policy Commission is also leading. And that's done in close collaboration with OHA.
Yeah, that's a really good point.
Mm-hmm.
Nicole, Tatiana, Jessie, thank you so much. You all are amazing, and this was a really fantastic session.